Welcome to a deep dive dedicated entirely to mastering the core clinical knowledge you need for excellence in medical surgical nursing.
That's right.
Today, we are tackling a really foundational area, the management of patients who are dealing with upper respiratory tract disorders.
And that's our whole mission here. We are taking a comprehensive look at this critical chapter, really just breaking down all the complex clinical information from the anatomy, pathophysiology, all the way to some really specific high-stakes nursing interventions.
So the goal is simple then.
The goal is simple. What are the must-know clinical facts from this respiratory chapter that you need, in your pocket right now? We want to make sure the knowledge is clear, it's memorable, and it's immediately applicable.
And we're going to cover the full clinical spectrum, right?
Yeah.
We're moving from the very common, like rhinitis and the common cold,
Right, the nuisance stuff.
all the way up through life-altering, even life-threatening conditions like laryngeal obstruction and cancer management. And we'll use the nursing process as our guide, making sure we cover assessment, diagnosis, interventions for every major concept.
Exactly.
Okay, so let's unpack this and set the clinical stage. For a nurse on the floor, where exactly is the line for the upper respiratory tract disorders we're talking about today?
So we're talking about all the structures that guide air into the lungs. So the nose, the paranasal sinuses, the pharynx, the larynx, the hypertrachea, and even the larger bronchi.
And the challenge here seems to be the huge range of severity.
It's all about the spectrum. You have the acute temporary inconvenience, like a viral rhinitis. But then on the other end, you have conditions like acute laryngeal obstruction or laryngeal cancer.
And those demand immediate, really developed assessment skills.
Absolutely, because they threaten the airway itself, and they often require permanent, really radical changes in how a patient breathes and, how they speak for the rest of their life.
The book really emphasizes those long-term needs for conditions that permanently alter function.
Yeah.
But for a nurse in a busy setting, where do you prioritize? Is it managing the acute airway or preparing for the patient's long-term communication and rehab needs?
That is such a critical question of prioritization. And in the acute phase, the airway always wins, period.
Always.
However, a really skilled nurse, they're weaving in that long-term view from the very beginning. So for a patient facing laryngeal cancer, for example, the nurse not only manages that immediate post-surgical airway patency,
Right.
but they also have to be aware of the long-term rehab needs. That means teaching and facilitating communication alternatives, right away. The two paths, acute survival and chronic quality of life, they're just woven together right from the diagnosis.
Okay, so to navigate this field, we have to establish a common language, and quickly. Let's start with those foundational inflammation terms, the D-itis family, because they get confused all the time.
We have to be specific. So rhinitis refers only to the inflammation of the nasal mucous membrane. And that's different from the term we prefer now, rhinosinusitis, which has replaced the older sinusitis.
So rhinosinusitis is broader.
It is. It means inflammation of both the nares, the nostrils, and all the paranasal sinuses. Then, of course, you have pharyngitis, inflammation of the throat, and laryngitis, which is inflammation of the voice box, the larynx.
Got it. Now, for some of those key clinical signs that you see in charting, starting with bleeding and discharge.
Okay, so epistaxis is simply a nosebleed. It's usually a hemorrhage from those tiny distended vessels in the anterior septum, or we call the Kieselbach plexus.
And a runny nose.
That's rhinorrhea. It's the technical term for excessive nasal drainage. And the quality of that discharge, is it clear? Is it purulent? Is it watery? That's absolutely vital in your assessment. It guides the diagnosis.
And when we look at potential complications, there's one physical sign that should trigger an immediate high-stakes alert.
Yes, that's neutral rigidity, so stiffness of the neck or the inability to easily bend the neck.
And in this context, that's a huge red flag.
A huge red flag. In the context of a URI, especially rhinosinusitis or pharyngitis that's getting worse, this is a critical complication sign. It often signals potential central nervous system involvement, like meningitis, and it requires immediate medical investigation.
Okay. And finally, related to the larynx and communication itself.
So aphonia is the inability to use one's voice, usually from swelling or some kind of injury to the vocal cords. And if a patient loses their larynx entirely, post-surgery, they'll engage in laryngeal communication.
Which is a whole new way of speaking.
It refers to all the alternative speech modes that bypass the natural voice box, and that becomes a massive part of their rehabilitation.
The sources explicitly flag that special considerations apply when we're dealing with URIs in older adults. For a new nurse, what is the single highest priority clinical difference we have to recognize in this population?
The highest priority is recognizing the risk of progression and complications. URIs that might be, a minor annoyance in a younger person can have far more serious consequences in the elderly.
Because of comorbidities.
Exactly, because they frequently have concurrent medical problems. Think about a patient with COPD or congestive heart failure. A simple viral infection can just tank their already reduced respiratory function, and that can lead to severe hypoxemia or even failure. And their immune system is, naturally compromised with age.
So if they go and grab the standard over-the-counter remedies, are we looking at a serious drug interaction or a different side effect profile?
Absolutely, and this is a massive area for caution. Common OTC remedies like antihistamines and decongestants, they have to be used very, very cautiously.
So what should a nurse be vigilant for?
Okay, so for instance, antihistamines can cause drowsiness and these anticholinergic effects, which can lead to confusion, urinary retention, and dangerously increase risk of falls in an older person. These simple drugs also have potential, sometimes fatal, drug interactions with that, long list of medications older adults are typically managing.
That's a powerful point. Are there specific upper respiratory conditions that are just more common because of the aging process itself?
Yes. For one, the prevalence of non-allergic rhinosinusitis is notably greater in older adults, but the structural changes are what I find most clinically fascinating.
Structural changes to the nose.
Yes, with aging, the nose actually changes shape. It lengthens, and the tip tends to droop because of the loss of cartilage.
That sounds like it's just a cosmetic issue, but if it's restricting airflow, it must have clinical consequences.
It does. That structural change restricts airflow, which is a mechanical issue that can predispose them to a specific condition we call geriatric rhinitis.
And what does that look like?
It's often characterized by this increased thin, watery sinus drainage that they never had before. And these anatomical changes, they also contribute to a declining sense of smell, which, affects their appetite and their safety.
And finally, the text links laryngitis in the elderly to a really common GI issue.
That's right. Laryngitis in older adults is very commonly secondary to GERD, gastroesophageal reflux disease. We call it reflux laryngitis.
So why is that connection so strong?
Well, since older adults are more likely to have impaired esophageal peristalsis and a weaker esophageal sphincter, that reflux material just easily irritates the larynx, leading to that chronic cough and hoarseness.
So the treatment has to focus on the GERD then?
Exactly.
Yeah.
You're prescribing histamine 2 receptor blockers, like famotidine or PPIs, like omeprazole, and you're recommending elevating the head of the bed, often with blocks or a wedge pillow.
Okay, let's transition into the infectious realm, starting with rhinitis. We often think of this as low stakes, but the clinical reality is that it impacts quality of life significantly.
It's really the gateway problem. While it seems minor, persistent rhinitis contributes to some significant issues, including chronic sinus problems, persistent ear problems, severe sleep disturbances, and it frequently acts as a trigger for conditions like asthma.
And it's categorized in a few ways.
Right. Acute or chronic, and then by cause. Allergic, which can be seasonal or perennial, or non-allergic, and the most common type there is just the common cold.
When we look at the pathophysiologic drivers, the sources list a really wide range of stimuli beyond just the typical allergens like dust or pollen. What are some of those non-obvious causes we should consider during an assessment?
It's a comprehensive list. Rhinitis can be triggered by simple environmental factors like sudden changes in temperature or humidity, exposure to strong odors, or underlying systemic diseases. But we also have to consider drug-induced cases.
Ah, yes, rhinitis medicamentosa, or drug-induced rhinitis. The list of prescription drugs involved is quite surprising. Wait, an ACE inhibitor? A drug for heart failure and hypertension causes a runny nose. How do we explain that connection to a patient?
And that connection is key, and it's often missed. ACE inhibitors like lisinopril can cause a persistent cough and, yes, rhinitis, likely by interfering with the breakdown of inflammatory substances in the respiratory tract.
What other drugs should be on our radar?
We have to look out for other common classes. Beta blockers, statins like atorvastatin, aspirin, and even some psychiatric medications. The text specifically names risperidone, an antipsychotic, as a potential cause.
And what about the most notorious cause, The one that's self-inflicted.
That is the overuse of over-the-counter nasal decongestants like oxymetazoline.
The rebound congestion.
Exactly, rhinitis medicamentosa. When that vasoconstrictive effect wears off, the mucosa swells up even worse than before, forcing the patient to use the spray again, and it leads to this vicious cycle in dependency.
So what's the rule of thumb?
Nurses must stress that topical decongestants should never be used for more than 3 or 4 consecutive days. Ever.
So what are the telltale symptoms we're assessing for with rhinitis?
The symptoms are classic. Rhinorrhea, nasal congestion, sneezing, and that pruritus, that intense itching in the nose, mouth, throat, eyes, and ears.
And if it moves into the sinuses?
Then the patient will also complain of a headache or some facial pressure.
And how does medical management stratify based on the cause?
If the cause is viral, it's purely symptomatic relief. If it's allergic, we move toward identifying the trigger, maybe through allergy tests, and treating with desensitizing immunizations or nasal corticosteroids. If it's bacterial, an antimicrobial agent is required.
Okay, so diving into the pharmacologic toolbox for symptom relief, what are the primary agents and how do they differ in their action?
The mainstays are antihistamines, which are fantastic for sneezing, pruritus, and that watery rhinorrhea. Oral decongestants, they work by reducing swelling to relieve obstruction.
And what about just a simple saline spray?
A simple foundational therapy. It's a mild decongestant, but more importantly, it liquefies mucus and it prevents crusting. For a more targeted action on rhinorrhea, you might see intranasal ipratropium prescribed.
And corticosteroids.
Intranasal corticosteroids are reserved for managing severe, persistent congestion. And for really complex allergic components, we often see adjunct therapies like leukotriene modifiers such as montelukast or IgE modifiers like omalizumab, which are often used in patients with asthma.
So nursing management here is really heavily weighted toward education and prevention. What are the core teaching points on avoiding flare-ups and infectious spread?
Prevention starts with avoidance. Patients have to be rigorously instructed to avoid or reduce exposure to known allergens and irritants. Dust, smoke, fumes, that sort of thing.
And for preventing infection?
Detailed review of hand hygiene technique is paramount, especially if the patient interacts with vulnerable populations. And we must also review the importance of an annual influenza vaccination, particularly for older and high-risk patients.
Let's focus on that crucial technique you mentioned earlier, the correct administration of nasal medications. Improper technique can make expensive medication totally ineffective. What are the 2 or 3 non-negotiable steps a nurse has to teach?
This is absolutely critical teaching. To ensure the medication reaches the right mucosal area and you avoid systemic absorption, the nurse must instruct the patient to do a few things. First, blow their nose thoroughly to clear the passage. Second, keep the head upright, spray quickly and firmly, and this is key, aiming the nozzle away from the nasal septum and toward the outer wall of the nostril.
And why away from the septum?
If the medication hits the septum, it can cause irritation or, even worse, perforate the septum over time. And third, wait at least 1 minute before administering a second spray and never share the container.
Okay, moving to the common cold, the most frequent viral infection. We know it's self-limited, but we need to underscore just how contagious it is and for how long.
It's highly contagious because the virus starts shedding about 48 hours before symptoms even appear.
Wow.
And it continues throughout that early symptomatic phase. This is why isolation is so ineffective. There are up to 200 different viruses that can cause a cold, with rhinoviruses being the most common.
And there's an environmental factor too, right?
There is. Cold-causing viruses actually survive better when humidity is low, which commonly happens when we turn on indoor heating during colder months, trapping people inside together.
How do the manifestations generally progress from the onset?
Early symptoms include congestion, rhinorrhea, halitosis, sneezing, a sore throat, and just that generalized malaise. A low-grade fever might be present. A cough usually shows up later as the illness progresses down the airway.
And Chart 18-3 details the highly contagious herpes simplex, or cold sores, which often accompany these illnesses. What's a high-stakes management point there?
Herpes labialis, HSV1, is extremely contagious. It's often transmitted through shared towels or razors. It lies latent, and then it's activated by physical stressors, emotional stress, sun exposure, or an infection like the common cold.
And the lesions progress.
They progress from those tingling macules to painful vesicles that crust over. But the critical management point is all about timing. Antiviral medications like acyclovir are only really effective if the patient seeks treatment at the very first symptom, that initial tingling or burning sensation, before the vesicles even form.
So for managing the common cold, what is the core medical strategy and what is the crucial avoidance point the nurse must reinforce?
The strategy is pure symptomatic therapy. So, fluid, rest, preventing chilling, warm saltwater gargles, and pain relievers like NSAIDs or acetaminophen.
And the avoidance point.
The crucial avoidance point, which cannot be overstated, is antibiotics. We must educate the patient that antibiotics are not used for viral rhinitis. They don't affect the virus, they don't reduce complications, and their inappropriate use just drives antibiotic resistance, which impacts the entire community.
What about those specific nasal decongestants? Again, we have to reiterate the warning.
Yes. Topical nasal decongestants should only be used for a maximum of 3 to 4 days. If a patient is using them daily for a week or two, they are suffering from rhinitis medicamentosa, that rebound rhinitis, where the nose becomes chronically dependent on the drug, causing terrible persistent congestion.
So the solution becomes the problem.
It's often worse than the original problem.
So what's the most effective prevention measure? And what does the nurse need to teach about respiratory etiquette?
Hand hygiene remains the single most effective measure to prevent transmission. We have to teach appropriate etiquette. Always use tissues, dispose of them properly, and if a tissue isn't immediately available, the patient must cough or sneeze into their upper arm, into the elbow, not their hands.
Okay, moving beyond the common cold, let's look at rhinosinusitis. The sources confirm this term has replaced sinusitis because sinus inflammation is almost always accompanied by inflammation of the nasal mucosa.
It's a hugely prevalent issue, and we classify it strictly by the duration of symptoms, which dictates the aggressiveness of the treatment.
So what are those classifications?
Acute is less than 4 weeks, subacute is 4 to 12 weeks, and chronic is more than 12 weeks. There's also recurrent acute rhinosinusitis, which is defined as 4 or more acute episodes per year with complete symptom resolution in between.
And what's the core pathophysiology here? It usually follows a viral URI or an allergic flare-up.
The problem is all about drainage. The initial inflammation and edema cause nasal congestion, which then mechanically obstructs those tiny sinus openings, the ostia.
And that blockage is the key.
It is. It prevents the normal drainage and aeration of the sinuses, creating a dark, stagnant, warm medium that is just perfect for bacterial growth. The common culprits are often streptococcus pneumonia and Haemophilus influenza.
You mentioned an important concept in chronic or recurrent infection, biofilms. Why are they such a game changer in rhinosinusitis and antibiotic failure?
Biofilms are a huge clinical problem. They are organized, complex communities of bacteria that secrete this protective matrix, and they're often found deep within the respiratory tract.
So they're mere resistant.
Extremely resistant. We're talking 10 to 1,000 times more resistant to antibiotics than regular free-floating bacteria. They act as reservoirs, meaning that even if an antibiotic course kills the surface layer of bacteria, the embedded cells survive and allow the infection to rapidly regrow.
Which is why compliance is so critical.
It's why compliance and sometimes those very long courses of antibiotics are non-negotiable for success.
This is maybe the highest stakes clinical triage point, distinguishing between acute bacterial rhinosinusitis, ABRS, and acute viral rhinosinusitis, AVRS, because that decision dictates antibiotic use. How do we tell them apart?
We have to remember the AVRS-ABRS triage is built on 3 crucial Ds: drainage, degree of fever, and duration.
Okay, so let's start with ABRS, the bacterial one.
For ABRS, you're looking for purulent nasal drainage, nasal obstruction, facial pain, pressure, or a sense of fullness, and a high fever of 39 degrees C, 102 degrees F, or higher.
And the duration is key.
Critically, a definitive bacterial diagnosis is often made if symptoms persist for 10 days or more without improvement, or, and this is a big one, if the symptoms initially improved and then suddenly got worse.
And for the viral version, AVRS.
AVRS presents similarly, but it's generally less intense. The fever is absent or low grade, the drainage is usually clear or non-purulent, and the symptoms occur for fewer than 10 days, and most importantly, they do not worsen over time, they trend toward improvement.
And what does the physical assessment involve? We don't just jump to imaging, do we?
No. We assess for localized tenderness to palpation over the infected sinuses, so pressing up under the supraorbital ridge for the frontal sinus, or on the cheekbones for the maxillary sinuses. A specific, painful test is the percussion test, just lightly tapping the sinuses with an index finger.
And imaging.
Diagnostics like X-ray, CT, or MRI are not standard unless you suspect complications or you're guiding surgery. The pathogen is only definitively confirmed via a sinus aspirate or a flexible endoscopic culture, which is pretty rare in general practice.
So the treatment goals are to shrink the mucosa, relieve pain, and treat the infection if it's bacterial. Let's talk about that 14-day antibiotic course for ABRS.
Antibiotics are reserved only if the criteria for ABRS are met, that 10-day persistence or the high fever. The standard course is 14 days to ensure complete eradication, especially considering the potential for those biofilms.
What are the first-line choices?
Amoxicillin or amoxicillin clavulanic acid. If the patient has a severe penicillin allergy, we turn to alternatives like doxycycline or respiratory criminolones such as levofloxacin.
And the sources emphasize that a lot of older antibiotic classes are now failing.
That's a key takeaway regarding resistance. The text specifically warns that older antibiotics like cephalosporins and macrolides, clarithromycin, azithromycin are frequently ineffective against the common resistant organisms in ABRS and should generally be avoided unless a culture sensitivity says otherwise.
What about adjunctive therapies? Does a patient with ABRS need antihistamines or decongestants?
It's a bit counterintuitive, but the source specifies that antihistamines and systemic decongestants are not recommended as effective adjuncts for ABRS.
But what is effective?
Intranasal saline lavage, using high-volume, low-pressure washes, is highly effective as an adjunct therapy to relieve symptoms and thin that stagnant mucus. And yes, we still caution against using topical decongestants for longer than 3 or 4 days.
Let's review nasal corticosteroids. When are they indicated, and what are the major safety concerns?
They are powerful and can significantly improve symptoms, but they're primarily recommended if the patient has a history of allergic rhinitis, as this suggests an inflammatory component that's responsive to steroids.
And the side effects.
They do have side effects, including nasal irritation, headache, and epistaxis. And critically, there are strong contraindications. All nasal corticosteroids should be avoided in patients with recurrent epistaxis, glaucoma, or cataracts. They also must be used with caution in patients exposed to measles or varicella or those with known adrenal insufficiency.
Now, CRS chronic rhinosinusitis is defined by symptoms lasting 12 weeks or longer. How is that diagnosis solidified?
The diagnosis of CRS requires symptoms for 12 weeks or more, including at least 2 of the core 4. Mucopurulent drainage, nasal obstruction, facial pain, pressure, fullness, or hyposmia, which is a decreased sense of smell. It's also notable that about 40% of CRS cases involve nasal polyps.
And what's driving this persistent chronic blockage?
The primary problem is a long-standing mechanical obstruction, typically in the osteomedial complex, those narrow drainage pathways.
What can cause that?
It can be caused by infection, allergy, or structural issues like a deviated septum. Furthermore, systemic comorbid conditions contribute. Cystic fibrosis, untreated GERD, and especially tobacco use are all strongly associated with driving and maintaining CRS.
And the clinical picture?
The clinical picture includes impaired mucociliary clearance, a persistent chronic cough, often from postnasal drip, hoarseness, chronic periorbital headaches, and chronic fatigue. Patients often complain their symptoms are worst right when they wake up, likely due to nocturnal stasis of secretions.
The medical management of chronic rhinosinusitis requires a more sustained approach than the acute version, I'm guessing.
Yes. While the core measures hydration, head elevation, avoiding irritants remain, the antibiotic course, if it's required, is significantly extended, typically 2 to 4 weeks, but sometimes prescribed for up to 12 months in really difficult cases.
So it's a long haul.
It is. Long-term treatment often relies heavily on corticosteroid nasal sprays and leukotriene inhibitors, especially if there is a concomitant asthma or allergy diagnosis.
And if medical therapy fails? SS functional endoscopic sinus surgery is the intervention.
FESS is a minimally invasive surgical option that aims to correct structural deformities, remove chronic polyps, and mechanically open those obstructed sinus drainage pathways. It actually boasts a very high success rate, offering relief in over 85% of carefully selected patients.
And a quick but terrifying note on fungal sinusitis, which is specifically relevant for the immunocompromised.
Acute invasive fungal rhinosinusitis is a catastrophic illness. It is life-threatening in immunocompromised patients, such as those with poorly controlled diabetes or severe neutropenia.
So what happens?
Organisms can rapidly invade and cause necrosis. This requires aggressive, immediate surgical debridement to remove the infected tissue and systemic antifungal medications, as delaying treatment can lead to very high mortality rates.
Let's consolidate the critical self-care education points for rhinosinusitis.
Okay, so we stress gentle nose blowing. Forceful blowing can actually force infection into the eustachian tubes or sinuses. We encourage drainage using humidification, warm facial compresses, and sleeping with the head of the bed elevated.
And what should they avoid?
During an acute episode, patients must avoid swimming, diving, air travel, and tobacco use. And crucially, they have to adhere to the full antibiotic regimen even if symptoms disappear quickly to prevent recurrence and resistance.
The sources provide two critical safety alerts for high-risk populations. Let's discuss the alert concerning medical tubes.
This is vital for the ICU nurse. Nasotracheal and nasogastric tubes pose a huge risk because they mechanically obstruct normal sinus drainage. An accurate assessment of a patient with these tubes is paramount.
So what's the intervention?
If a sinus infection develops, these tubes must be removed as soon as the patient's condition permits to allow drainage. This prevents severe septic complications that can result from all that retained purulent material.
And the second alert focuses on the immunocompromised patient, a common theme.
For these patients post-transplant chemotherapy, HIV URIs may present with blunted or entirely absent symptoms because of their immune suppression.
And the risks.
The nurse must recognize that they are at increased immediate risk for rapidly progressing fungal infections. So, immediate assessment and reporting of any subtle changes are essential, as delayed treatment can be fatal.
And that final, overarching warning sign of severe progression.
Any report of a persistent or high fever, a severe headache, or the onset of neutral rigidity, that neck stiffness, signals a progression to a central nervous system complication like meningitis, and it requires emergency intervention.
All right, moving to pharyngitis, the common sore throat. This is a sudden, painful inflammation that peaks in winter and early spring. As nurses, the primary triage question isn't, is it a sore throat, but is it strep?
Exactly. Most cases are viral adenovirus, influenza, HSV, but 5% to 15% of adult cases are bacterial, and the pathogen we fear most is group A beta-hemolytic streptococcus, or GBHS, strep throat. We have to catch it.
What are the classic manifestations that should raise suspicion for GBHS over just a common viral sore throat?
A viral pharyngitis generally shows red tonsils, swollen nodes, and the absence of a cough. GBHS is typically more severe. A sudden onset of a severe sore throat, high fever 101 or higher malaise, nausea, and sometimes that scarlatina-form rash, scarlet fever. The intensity is often the first clue.
Why is identifying and treating GBHS so imperative, especially given the 2 to 3 week complication lag time?
Untreated GBHS carries severe systemic risks. While local complications like a peritonsillar abscess are dangerous, the major long-term danger is the delayed onset of these immunological disorders.
Like
Acute rheumatic fever, which can cause valvular heart damage, and acute glomerulonephritis, which can cause kidney failure. These complications develop after the initial infection has resolved, often 2 to 3 weeks later, which is why eradication is so important.
how quickly can we confirm strep, and what's the gold standard treatment?
Diagnosis uses the Rapid Antigen Detection Test, or RADT, which provides results within minutes and has a high sensitivity. This allows for immediate treatment and quick reduction of transmission.
But what if it's negative?
We have to remember that negative RADT results are still typically confirmed by a throat culture, especially in high-risk patients, to prevent missing a true strep infection.
And the treatment?
Once bacterial pharyngitis is confirmed, the treatment gold standard is penicillin V potassium orally for 10 full days. If the patient is penicillin allergic, alternatives include cephalosporins or macrolides like clarithromycin, but that 10-day duration is mandatory to prevent those delayed complications.
And since swallowing can be excruciatingly painful, what nutritional interventions do we focus on?
We prioritize maintaining hydration and reducing pain. The patient needs a liquid or a soft diet. We recommend soothing options, cool beverages, warm liquids, or frozen desserts like ice pops.
And fluids are key.
High fluid intake, at least 2 to 3 liters per day, is crucial for thinning secretions and preventing hypovolemia. In severe cases where pain prevents any oral intake, IV fluids are necessary.
Let's focus on comfort and infection control. Two critical nursing interventions here.
Okay, comfort measures include bed rest during the febrile stage, warm saline gargles, or throat irrigations. At a comfortable temperature, about 105 to 110 degrees Fahrenheit, help reduce muscle spasm and soreness. An ice collar applied to the neck can also be very effective for relieving severe pain.
And what are the specific infection control teaching points, including a note about personal items?
Proper disposal of tissues is essential. And the nurse must specifically instruct the patient to change their toothbrush after the infection is cured, as the bristles can harbor the bacteria.
What else?
They must also avoid sharing utensils and ensure they cover their cough or sneeze into their upper arm, not their hand.
We have to reinforce that 10-day antibiotic course one more time, making the consequences really clear.
We have to be relentless about this education. The nurse has to stress that the patient must take the full course of antibiotics. If they stop after 3 days because they feel better, they risk incomplete eradication.
And that allows the surviving bacteria to do what?
To trigger the dangerous immune responses that lead to nephritis or rheumatic fever 2 to 3 weeks down the line, we have to emphasize that they are taking the last 7 days of pills not for their sore throat, but for their heart and their kidneys.
Briefly, for chronic pharyngitis, that persistent, long-standing inflammation, what are the types and what is the primary management strategy?
The types are hypertrophic, thickening of tissues, atrophic, a late stage with a thin, whitish membrane, and chronic granular swollen lymph follicles.
And management.
Management relies on avoiding irritants above all else. No alcohol, no tobacco, no secondhand smoke, and minimizing exposure to pollutants. For occupational exposure, they might need an N95 mask.
What is that subtle but important red flag symptom that suggests the pain is not just pharyngitis?
If the patient complains of a sore throat that worsens with swallowing, but they do not show that fiery redness or exudate typical of pharyngitis, that pattern suggests the possibility of thyroiditis, which requires a specific referral and management.
Okay, let's move to tonsillitis, adenoiditis, and the peritonsillar abscess. Tonsillitis and adenoiditis involve the infection of lymphatic tissues. We think of it as a childhood issue, but adults get them too.
They do, with GABHS and Epstein-Barr virus being common culprits, and enlarged adenoids are particularly troublesome because they obstruct the nasal airway. This forces mouth breathing, which leads to a dry mouth, earaches, and noisy respiration. Air travel can become painful because they can't properly equalize pressure.
What are the serious complications associated with persistent infection here?
The infection can spread directly to the middle ear via the eustachian tubes, causing acute otitis media or a chronic low-grade infection. And if that's left untreated or it's recurrent, this chronic infection can eventually lead to permanent hearing loss or even deafness.
So when do we escalate the problem to a surgical solution, a tonsillectomy or adenoidectomy for adults?
Surgery is indicated only after a few factors are met. Repeated episodes despite rigorous antibiotic management, hypertrophy so severe it's causing airway obstruction and obstructive sleep apnea,
Okay.
recurrent purulent otitis media, or, crucially, persistent tonsillar asymmetry. Asymmetry means surgery because it has to be biopsy to definitively rule out lymphoma.
Post-op care is extremely high risk, largely focused on preventing and detecting hemorrhage. What is the immediate, non-negotiable nursing priority?
Continuous vigilant nursing observation is required in the immediate post-op period. The safest position is prone with the head turned to the side, and you maintain this until the gag and swallowing reflexes have fully returned.
And that's to prevent aspiration.
It facilitates the drainage of oral secretions and any blood from the mouth, preventing aspiration.
So how does the nurse monitor for swallowed blood effectively, and what's the difference between active and, say, occult bleeding?
We apply an ice collar immediately to reduce swelling and local bleeding. The nurse has to monitor closely for signs of swallowed blood. If the patient is spitting up bright, active red blood, that is an obvious emergency.
And if they're swallowing it?
If the patient is swallowing the blood, it mixes with the acidic gastric juice and will be seen as dark, brown, or coffee ground material if they vomit. A rising pulse, restlessness, and increasing temperature require immediate notification of the surgeon, as these are signs of active internal hemorrhage.
And the risk isn't over right away.
We have to remember that delayed hemorrhage is a risk for up to 8 days post-op, often triggered by the stabs dissolving.
Moving to discharge teaching, what are the dietary and activity restrictions for the patient going home?
We stress pain management using liquid analgesics. Pain subsides over 3 to 5 days. Dietary instructions are crucial. Avoid spicy, hot, acidic, or rough foods for at least 10 days, because mechanical or chemical irritation can dislodge clots and trigger bleeding. Patients should also avoid vigorous toothbrushing, gargling, smoking, and heavy exertion for the same period.
Okay, now the peritonsillar abscess, or quinsy, this is a severe complication. We noted it's life-threatening if the edema progresses. What are the 3 classic symptoms that make this easily identifiable?
The patient is acutely, obviously ill, with a high fever and excruciating sore throat. The 3 classic signs are: first, Trismus, the inability to open the mouth fully due to muscle spasm.
Second.
Second, drooling, because swallowing saliva is too painful. We call that odonophagia. And third is the intense, often radiating ear pain or otalgia.
And what would you see on examination?
You'd have to look for the uvula. The infected tonsil pushes it dramatically toward the opposite side.
So management requires both medical and urgent procedural intervention.
It does. Medical treatment begins immediately with high-dose IV antibiotics, usually penicillin and corticosteroids, to reduce the swelling. If the abscess doesn't resolve rapidly, surgical management is needed.
Which would be what?
Needle aspiration is preferred due to high efficacy and low cost, or an incision and drainage. The critical nursing role here is ensuring the patient is sitting fully upright during these procedures so they can expectorate any pus or blood safely and prevent aspiration.
All right, laryngitis, inflammation of the larynx, is primarily viral but often caused by voice abuse, irritants, or GERD. What is the critical manifestation and what is the simple foundation of management?
The primary manifestation is hoarseness or, in severe cases, complete aphonia. Chronic laryngitis is marked by persistent hoarseness. Patients often complain of a persistent tickle and feel worse in the morning.
And management.
It's all about voice rest, minimal speaking, and eliminating irritants like smoking. If reflux is the cause, treatment shifts entirely to managing the GERD using PPIs.
There is a vital nursing alert regarding hoarseness duration that suggests possible malignancy. How long is too long?
This is a critical safety point the nurse must enforce. Hoarseness persisting longer than 5 days, even after rigorous voice rest and avoiding irritants or any sign of coughing up blood, hemoptysis, must be reported to the primary provider immediately. Persistent hoarseness is the #1 symptom that raises the possibility of malignancy.
Okay, now let's apply the comprehensive nursing process framework to a patient with a high-stakes upper airway infection. Let's start with the targeted assessment.
The assessment has to be comprehensive. We need a detailed history of onset, precipitating and relieving factors, and a complete allergy review. The physical exam is key.
What are you looking for?
You inspect the nose for swelling, polyps, and discharge. We look closely at the turbinate mucosa. If it's chronically inflamed, it'll appear swollen, pale, and bluish-gray or boggy. We palpate the sinuses for tenderness and inspect the throat for redness and exudate. Finally, the neck must be palpated for enlarged, tender cervical lymph nodes.
Based on this assessment, the sources provide 4 core nursing diagnoses we should prioritize.
Right. First, impaired airway clearance from all the excess mucus. Second, acute pain from the irritation and swelling. Third, impaired verbal communication from the hoarseness or swelling. And fourth, hypovolemia from decreased fluid intake and increased fluid loss from fever.
So let's review the key interventions for these diagnoses, starting with maintaining a patent airway.
To maintain a patent airway and loosen secretions, we increase fluid intake dramatically and recommend using room vaporizers or steam inhalation. Positioning is also therapeutic. An upright position promotes drainage, particularly for patients with rhinosinusitis.
And how do we promote comfort beyond simple systemic analgesics?
We use the pain scale rigorously. Beyond NSAIDs or acetaminophen, we can use topical anesthetic agents for localized relief, like for herpes simplex or a severe sore throat.
What about hot or cold packs?
For rhinosinusitis congestion, hot packs over the sinuses are often helpful. For pharyngitis or tonsillitis pain, warm water gargles are used. And post-tonsillectomy, an ice collar is essential to reduce swelling and bleeding.
Given the risk of hoarseness or aphonia, how does the nurse facilitate communication, which can be immensely frustrating for the patient?
The instruction is to minimize speaking and rest the voice entirely. We have to provide accessible alternative methods right away: writing, memo pads, or electronic devices. And the nurse has to be incredibly patient, recognizing that writing out needs is frustrating and time-consuming for the patient.
Okay, finally, combating hypovolemia. What's the fluid goal?
The goal is 2 to 3 liters per day, unless it's contraindicated by comorbidities like heart failure. We offer easy-to-ingest, comforting foods, soups, yogurt, pudding, ice pops to make sure their caloric and fluid needs are met during that acute, painful phase.
Okay, now let's talk about obstruction and trauma of the upper airway, starting with obstructive sleep apnea, or OSA. This affects about 26% of adults, with up to 90% believed to be undiagnosed. This is a huge public health issue.
It absolutely is. The high prevalence is inextricably linked to current obesity rates, but key risk factors also include a large neck circumference, male gender, advanced age, and postmenopausal women. The sources even mandate that all hypertensive adults should be screened for OSA.
And that highlights the cardiovascular consequences.
It does. Let's delve into the core pathophysiology. How does the upper airway collapse during sleep?
So pharynx is naturally a collapsible tube. During sleep, muscle tone is dramatically reduced. In susceptible individuals, those with excess fat around the pharynx or structural issues, the negative pressure created by inspiration just pulls the walls of the airway closed,
And this leads to repetitive apneic events.
lasting 10 seconds or longer. And the consequences are entirely systemic.
Yes. Repetitive apnea causes hypoxia and hypercapnia, so oxygen drops and CO2 builds up. The brain registers this danger and triggers a sympathetic stress response. The body releases adrenaline.
And that response, repeated hundreds of times a night.
Is the mechanism that links OSA directly to chronic hypertension, myocardial infarction, and stroke.
What are the classic clinical manifestations nurses look for? The forces simplify this using the 3 S's.
The 3 S's are an excellent screening tool. First, snoring. Frequent, very loud, often interrupted by silence. Second, sleepiness. Excessive daytime hypersomnolence, often pathological. They fall asleep during meals or even while driving. And third, significant other report of apnea.
That's a crucial one.
The observation by a partner that the patient stops breathing for 10 seconds or longer, at least 5 times an hour.
The definitive diagnosis relies on the gold standard, polysomnography.
The overnight sleep study. It monitors EEG, ECG, airflow, oxygen saturation, and respiratory muscle effort. For OSA, the key finding is that the apneic episodes last 10 seconds or longer, and they happen with continuous respiratory muscle effort. The patient is trying to breathe, but the airway is physically blocked.
Management starts with lifestyle changes, but quickly moves to mechanical support.
Initial steps are weight loss, avoiding alcohol before bed, and positional therapy. Oral appliances, specifically Mandibular Advancement Devices, or MADs, are now considered first line and are often as effective as CPAP for mild to moderate OSA.
And for severe cases,
For severe cases, it's Continuous Positive Airway Pressure, CPAP, or Bilevel Positive Airway Pressure, BiPAir, often with supplemental oxygen to create a pneumatic splint and prevent collapse. Surgical options are reserved for severe unresponsive cases.
and for residual sleepiness, there's pharmacologic help.
For those who adhere to CPAP but still experience that debilitating daytime sleepiness, drugs like modafinil or armodafinil are approved, but the nurse must ensure the patient understands these are adjuncts and not substitutes for mechanical airway support.
Okay, epistaxis, the nosebleed. It's common, but posterior bleeds can be highly dangerous. Where does the bleeding most commonly originate?
Most bleeds are anterior, originating in the Kisselbach plexus, that collection of tiny vessels on the anterior septum. Posterior bleeds are higher up, less common, but they're typically much more profuse and harder to control.
The risk factors are varied. Beyond local trauma, what systemic issues significantly increase risk?
Local factors include, nose picking, infections, and dry membranes. But the systemic factors are critical. Uncontrolled hypertension, arteriosclerosis, liver disease, and the use of antiplatelet or anticoagulant medications like aspirin or warfarin. Nurses have to assess the whole clinical picture, not just the nose.
What is the initial medical management the nurse should teach the patient to do immediately?
The patient must sit upright, leaning the head slightly forward to prevent blood from flowing down the pharynx.
Not backward.
No, never backward. That can cause nausea or aspiration. The most effective initial step is to pinch the soft outer portion of the nose firmly against the midline septum for a full 5 to 10 minutes continuously. If that fails, a vasoconstrictor spray like phenylephrine may be used.
And if it's a posterior bleed or it's persistent,
Then advanced treatment is required. Cauterization or nose packing using gauze or an inflatable balloon catheter, which might stay in place for 3 to 4 days. And when packing is used, antibiotics are almost always prescribed due to the high risk of secondary rhinosinusitis.
so nasal obstruction and fractures. Obstruction creates chronic mouth breathing, leading to dry mouth and sleep deprivation.
Right. And management starts with medical options, nasal corticosteroids and oral leukotriene inhibitors. For fixed hypertrophy or a deviation, surgical reduction or functional rhinoplasty is often indicated to improve the airway.
Nasal fractures are the most common facial fracture. What is the most critical assessment red flag that signals a need for emergency intervention?
We assess for pain, swelling, and bruising around the eyes. The critical red flag is clear fluid draining from the nostril.
And that means
That suggests a fracture of the cribriform plate and a cerebrospinal fluid, or CSF, leak. That means the cranial vault has been breached, posing a severe meningitis risk. The nurse must also always rule out concurrent cervical spine fractures if the trauma was severe.
Okay, now laryngeal obstruction. This is a definitive life-threatening emergency. Swelling of the laryngeal membranes can close the glottis in minutes. What are the major causes?
The causes are varied and require immediate recognition. Anaphylaxis leading to angioedema, foreign body aspiration, a rapidly growing tumor, or a recent infection like epiglottitis.
And there's a non-obvious cause to screen for.
Yes. Medication side effects, particularly swelling caused by ACE inhibitor use or rare genetic conditions like hereditary angioedema.
What are the immediate clinical manifestations? The sources warn against relying on one particular vital sign.
Patients will quickly show signs of air hunger, low oxygen saturation, visible use of accessory muscles, and retractions in the neck or abdomen. But crucially, the sources warn that a normal oxygen saturation should not lull the nurse into a false sense of security. The obstruction may be progressive and collapse could be imminent.
Management is urgent.
Immediate treatment follows CPR principles. Securing a patent airway. If foreign body removal is unsuccessful, an emergency tracheotomy may be required. If the obstruction is due to allergic edema, the treatment is immediate subcutaneous epinephrine administration and IV corticosteroids to rapidly reduce swelling.
We'll conclude with cancer of the larynx, which accounts for half of all head and neck cancers, predominantly affecting men over 65. What are the specific risk factors that make this cancer highly preventable?
The risk factors are almost entirely related to self-exposure, tobacco use in all forms. Cigarettes, cigars, smokeless tobacco, secondhand smoke, vaping is the primary driver.
And alcohol.
It's synergistically amplified by heavy alcohol consumption. The combination of alcohol and tobacco is profoundly dangerous, exponentially increasing the risk beyond using either substance alone. Other exposures include asbestos and wood dust.
What is the single most important early clinical manifestation that dictates a timely diagnosis?
For tumors located on the vocal cords, the key early sign is hoarseness lasting longer than 2 weeks. Because the tumor immediately interferes with the vocal cords, the voice sounds harsh, raspy, or lower in pitch. This early symptom is the patient's best chance for early-stage diagnosis and voice preservation.
And what about later symptoms when the tumor has advanced?
Later symptoms include a persistent cough or sore throat, difficulty swallowing or dysphagia, difficulty breathing or dyspnea, foul breath, and unintentional weight loss. Pain radiating to the ear often signals further metastasis.
Diagnosis begins with visualization, but how is the definitive diagnosis made and what are the crucial treatment goals?
The initial evaluation is an indirect laryngoscopy. The definitive diagnosis, however, requires a direct laryngoscopy under anesthesia, where tissue samples are obtained for biopsy. Imaging is used to stage the tumor.
And the goals are complex.
The overarching treatment goals are to achieve a cure, preserve safe and effective swallowing, preserve a useful voice, and ideally avoid a permanent tracheostomy. And crucially, before any surgery or radiation begins, a full dental exam must be completed.
Let's distinguish between voice-bearing surgery for early-stage tumors and total removal. What are the key voice-bearing options?
These include vocal cord stripping, a chordectomy, and laser microsurgery. The most complex is a partial laryngectomy, which removes part of the larynx and usually one vocal cord. The airway remains intact, swallowing is safe, and the patient's expected to retain a voice, though it will be very hoarse.
And for advanced or recurrent cancer, the total laryngectomy is required. The nursing implications are immense, starting with the permanent alteration of the airway.
A total laryngectomy removes the entire larynx. The consequence is immediate and permanent. The patient loses their natural voice entirely, and they require a permanent surgical opening in the neck, a stoma, or permanent tracheostomy.
Which changes everything about airflow.
The implication is profound. Air bypasses the nose and mouth entirely, going directly through the stoma into the lungs. This requires constant vigilance for humidification and stoma care.
The psychological weight of losing one's voice is immense. Preoperative discussion of communication methods is vital. What are the 3 primary techniques for laryngeal communication?
First is esophageal speech. This involves compressing air into the esophagus and expelling it to create a vibration. It requires extensive practice, and the success rate is relatively low.
Okay, second.
Second is the artificial larynx, or electric larynx. It's a battery-powered device held against the throat that projects sound into the oral cavity. The voice is mechanical, but it's an immediate communication option.
And the third, and most common.
That's the tracheoesophageal puncture, or TTEP-P. This is the most widely used and successful method, producing speech that most closely resembles a normal voice. A surgically created valve diverts air from the lungs into the esophagus and out the mouth for phonation.
So let's run through the complex nursing care required for the laryngectomy patient, starting with preoperative assessment. We have to look beyond just the surgical site.
Preoperative assessment must prioritize nutrition checking, albumin, protein, and BMI, as this directly impacts wound healing. We have to assess their baseline ability to read and write, as this dictates the immediate post-op communication plan.
And you screen for substance use.
Critically, screening for alcohol abuse is non-negotiable. Sudden cessation post-op can trigger severe delirium tremens. We also assess smoking status and the need for nicotine replacement.
Postoperatively, maintaining a patent airway is the absolute priority, but now that airway is the stoma.
The laryngectomy tube is intentionally shorter and larger than a standard tract tube. The patient is positioned in semi-Fowler or Fowler position to promote lung expansion and decrease surgical edema. We monitor for restlessness or decreased FbO2, which are immediate signs of hypoxia.
And stoma and tube care require specialized knowledge. What is the biggest danger of bypassing the nose's natural function?
The biggest danger is thick secretions and mucus plugs. Since the air bypasses the natural moisturizing function of the nose, humidification of the inspired air is paramount to prevent mucus from drying, crusting, and causing a fatal airway obstruction.
And stoma care.
The stoma must be cleaned daily with soap and water, and the nurse has to ensure the ties are secure to prevent accidental dislodgement, as this is the patient's only airway.
Communication post-op requires immense dedication and patience from the nurse.
We have to facilitate communication immediately using accessible tools like communication boards, tablets, or notebooks. And the nurse has to remember that this process is physically and emotionally taxing for the patient. So patience is absolutely essential.
Nutrition is a long-term challenge, with patients often NPO for over a week.
They're typically NPO for 7 or more days, relying on IV or enteral feedings. Before any oral feedings begin, a formal swallow study is mandatory to evaluate aspiration risk. We start with thick liquids, which are easier to control than thin ones.
Finally, managing complications, starting with the most feared one, hemorrhage and potential carotid rupture.
Active bleeding from drains or the trachea requires immediate notification of the surgeon. The absolute emergency is carotid artery rupture, often precipitated by wound breakdown near the stoma.
And what's the intervention?
If this occurs, the nurse must apply direct pressure immediately, summon help, and initiate treatment for hemorrhagic shock. This is a terrifying but life-saving intervention.
And other complications.
Other critical management points include preventing aspiration, which we do by positioning the head of the bed at 30 degrees or higher during and after tube feedings. We also teach preventative measures for tracheostomal stenosis, that abnormal narrowing, by ensuring meticulous stoma care.
To conclude the care plan, let's review the crucial self-care education for safety and hygiene once the patient goes home.
The patient and caregiver must be proficient in stoma care and suctioning. Safety education is essential. The patient has to wear a loose-fitting bib or hold a hand over the stoma when showering, and they must avoid swimming due to the risk of drowning.
They need to alert others, too.
They need to alert barbers and beauticians to avoid sprays or powders near the stoma. And most critically, they have to carry medical identification, a card or bracelet, to alert emergency personnel that mouth-to-stoma ventilation is required during resuscitation.
We've navigated the entire challenging spectrum of upper respiratory disorders, from rhinitis treatment protocols to that intricate, highly specialized post-laryngectomy care plan. We really saw how the nursing process provides a solid structure.
Absolutely. And remember those essential clinical distinctions that define expert care. That 10-day rule for strep, the danger of rhinitis medicamentosa, the 3 S's of OSA screening, and the life-saving urgency required for airway swelling. For our future nurses, synthesizing these layers is truly the definition of excellence.
So what's the big question to take away from this deep dive? We extensively explored the structural changes of the aging airway and the risks posed by comorbidities, specifically noting the high prevalence of undiagnosed OSA.
Consider this. Given the established link between obstructive sleep apnea and severe outcomes like stroke and myocardial infarction, how might proactive high-risk screening for OSA in all hypertensive older adults fundamentally change the trajectory of age-related cardiovascular disease in the next decade, transforming what was once a sleep issue into a preventative cardiac intervention?
That's a fascinating pathway for future exploration, and it really positions the nurse at the center of long-term prevention. Thank you for joining us for this deep dive.